Thank you, Mary. Good morning, everyone, or good afternoon. To me, it's good morning, so I am so happy you guys are all attending this webinar. Our topic of discussion today is CDI, getting back to the basics and best practice. And, Marie just gave a presentation of myself, so I'm just going to add that I am an active member of the Vitalware team here in Health Catalyst, and I'm a revenue transformation senior consultant. Just a short disclaimer statement. This presentation was current at the time it was published or provided via the web, and is designed to provide accurate and authoritative information in regard to the subject matter covered. The information provided is only intended to be a general overview, with the understanding that neither the presenter nor the event sponsor is engaged in rendering a specific coding advice. It is not intended to take the place of either the written policies or regulations. We encourage participants to review the specific regulations and other interpretive materials as necessary. All CPT codes are trademarked by the American Medical Association, and all revenue codes are copyrighted by the American Hospital Association. So, before I go into the objectives of our webinar, I would like to start by making some clarification. The CDI as such came out to light back in 2007, right after Medicare implemented the MS DRG system. Back in those early days, the profession was known as clinical documentation improvement. Throughout the years, and due to the fact that the revenue cycle and the prospective payment systems had gotten a little bit more complicated, the name of the CDI has changed. Nowadays, officially is known as clinical documentation integrity. Personally, I do agree with the change. Traditionally, when we were establishing the profession, some providers were not happy by us coming and telling them, we are going to improve your documentation. Some of them took it like we were implying like their documentation was not good. And so the bottom line now with integrity is a lot more broad coverage. And you know, to me, it's a lot more descriptive on what we do. Throughout the presentation of our webinar, I'm going to be using the term CDI. Sometimes I might be saying clinical documentation improvement or clinical documentation integrity. They apply to the same field. So the objectives of our webinar are to improve the health revenue cycle through best clinical documentation, coding, and reimbursement. Being able to identify the players in CDI, nurses, physicians, and HIM personnel. I'm going to explain more in detail about these participants later on. Be able to identify the goals of CDI, identify what the role of a provider in CDI is, being able to differentiate between an MS DRG and an APR DRG, be able to state how a DRG is calculated, and recognize the elements of reimbursement. Even though we are going to go in detail through those elements of reimbursement, I just wanted to present like a little summary of them. They are the hospital blended rate, the geometric length of stay, or GMLOS, the relative weight, and the case mix index. So we are going to do a little overview of what is CDI. Well, CDI is the process of enhancing medical data collection to maximize claims, reimbursement revenue, and improve care quality. Payers rely on clinical documentation and accurate coding to justify value-based reimbursement. This value-based reimbursement, as I was stating at the beginning of our webinar, is so important. I mean, traditionally, the payment, the prospective payment systems have been looking at the sick or the sicker or the sickest patient. With the value-based reimbursement, the value-based models, what we are looking is at a whole integration of the patient, let's say. Value-based programs not only consider what the acute problem of my patient is as of today, they look at previous history of the patient. They look at chronic conditions. And based on that, depending on the condition, on the chronic condition, they are able to do risk factor adjustments. So this is like the future of the revenue cycle, the value-based models. And I'm going to give you a quick description of CDI. Okay, CDI bridges the gap between the clinical language and the coding language. And you might say, what is that gap? You know, a gap is like a blockage. Let's assume you have a patient that has a known diagnosis of cancer. This patient is in remission, is taking chemotherapy, and he's got a long clinical history and, of course, a big medical chart. He is admitted for a gastrointestinal bleeding, okay? And at the time of coming into the hospital, the doctor is just documented as a principal diagnosis, just anemia. We come to the time of discharging, and then our coder, the coder is kind of confused because he's looking through the chart and is looking at the history of cancer. A patient is having chemotherapy, and a patient had got a history of anemia in chronic diseases, a history of anemia in neoplastic diseases. So at this stage, he is with no avail because anemia is so unspecific. So the CDI person is going to communicate with the attending physician, and the attending physician comes up with the clarification of the diagnosis. In this case, the diagnosis is going to be acute blood loss anemia, which is a lot more specific. Something we look in CDI is for specificity. Okay, the CDI is a team approach using concurrent or retrospective reviews of the clinical documentation and data in the medical record. Okay, a team approach, meaning that we have to interact with nurses, with case managers, with HIM personnel, and of course with the attending physician. And we do two kinds of reviews. One of them are the concurrent reviews. This means that the patient is still in the hospital, and while the patient is in the hospital, the CDI team is browsing through the chart and getting to identify any pieces of documentation that are not properly integrated, and querying the doctor if necessary to get a chart that is current and is completely accurately coded. The retrospective reviews. These are the reviews that are performed later on, right after the patient is being discharged, maybe like 6 weeks after the patient is being discharged. Chances are the bill has been, the hospital has been paid. And these retrospective reviews are sometimes performed by hospitals who hire CDI auditor personnel to review the previous documentation and to isolate problems that might be corrected in the future in the clinical documentation. And the purpose of those reviews is to identify any and clarify any vague, incomplete, missing, or contradicting clinical documentation in order to support patient care, accurate coding, and reporting of the true severity of the patient illness. I'm going to give you an example of each one of these situations, like when we have some vague clinical documentation. Vague clinical documentation would be, for instance, a patient that came up because of an abdominal problem and got an acute abdominal condition, let's say cholecystitis, and requires surgery. Well, next day, the patient, the doctors are doing the rounds, and one physician might say and might dictate, patient is doing fine, the wound looks good. Well, that's vague documentation. Something expected would be like, okay, this patient is on his first 24 hours of postoperative period, post-cholecystectomy, and is presenting with 12 centimeters of a surgical wound, which looks clean. The borders are approaching properly, and there are no signs of infection. So that's a more complete description of the wound of this patient. And then we have the incomplete piece of documentation. Let's say the same patient, when he came to the hospital, he was having a severe abdominal pain. Something incomplete will be the doctor saying, well, the patient is a 28 years old male, and it came with a severe abdominal pain. That's it. Well, that's incomplete. Something complete will be, okay, the patient is a 28 years old male who came in with 12 hours of evolution of a severe acute pain on the lower right-hand side quadrant of the abdominal area. And the pain irradiates to the back and is exacerbated with certain foods, and it gets relief with over-the-counter medication, etc. So that's a more complete form of describing the abdominal pain. Missing a documentation. Every time we admitted a patient, the patient goes through the development of a history and physical. History and physical has several sections. Missing documentation might be the case of the doctor omitting the family history, or it's not giving us the allergies the patient might have to medication or to any drugs. So that's missing information. And lastly, is the case of contradicting clinical information. Let's have a scenario in which a patient is admitted because of asthma exacerbation. And then you see, or the CDI looks at the notes, and it says that the patient is responding to inhaled corticosteroids. And something important, they are giving him beta agonist, and the patient is responding to this therapy. Then there is a progress note where it says that the patient got status asthmaticus. Well, the status asthmaticus is a patient in which his or her asthma is so bad that do not respond to beta agonist treatment. So in here, there is like a contradicting piece of information. Most likely, the clinical documentation improvement specialist is going to generate a query for clarification. Who are the CDI specialists? CDI specialists are nurses, physicians, health information management professionals, and other professionals with clinical and coding backgrounds. Certification is available through AHIMA and ACDIS. AHIMA is the American Health Information Management Association, and ACDIS is the Association of Clinical Documentation Improvement Specialists. I've seen great nurses performing CDI, and I've seen some nurse practitioners and even super specialists in nursing, like doctors in nursing performing CDIs. They do great jobs. I've seen physicians changing her practice to becoming a CDI. This was not my case, by the way, but I've seen some people doing that. And you see health information management professionals, basically the registered health information associates or the registered health information technicians, and they do great clinical documentation improvement personnel. The requirements to become a CDI. Okay, you have to have 2 years of clinical documentation improvement experience, and you have to have some college education. And then you have to sit for an examination with AHIMA and or ICDIS. CDI specialists analyze and interpret clinical documentation and data for clinical, laboratory, and radiology indicators. Radiology is so like a broad term, and maybe MRIs, maybe CT scans, and treatments required for accurate representation of the severity of illness, expected risk of mortality, and complexity of care of the patient. What are the goals of CDI? Well, is identify and clarify missing, conflicting, or non-specific physician documentation related to diagnosis and procedures, support accurate diagnosis and procedural coding, DRG assignment, severity of illness, and expected risk of mortality leading to appropriate reimbursement. And improve communication. Communication is a very important word between physicians and other members of the healthcare team. Hospital and physician profiles and quality of medical care. So I was saying communication, and I'm going to go back to the previous slide, and we're looking here at these clinical and laboratory radiologic indicators. I'm saying all of this because the CDI has a very, very important tool of communication with the physicians or the attending providers. And that communication is established to the query. And the way AHIMA defines a query, they say a query is a communication tool or process used to clarify documentation in the health record for documentation integrity and accurate code assignment for an individual encounter in any healthcare setting. We have come to a really important point. A medical record could be a legal record, and it's the same with a query. AHIMA and ICDIS, they have developed this set of guidelines for achieving a compliant query practice. And they say a leading query is one that is not supported by the clinical elements or the clinical indicators in the health record, and or directs a provider to a specific diagnosis or procedure. The justification, for instance, the inclusion of relevant clinical indicators for the query is more important than the query format. So I was saying a little while ago, I mean, if you are leading a physician is not good. Let's say you have a patient who presents with asthma or COPD exacerbation. That's the principal diagnosis. And then you are browsing through the chart and you identify some clinical indicators of acute respiratory failure. The person has shortness of breath. He or she is unable to elaborate a complete phrase without the need of grasping for air. The concentration of oxygen on the gas laboratory values is low, and you know, the patient is receiving assistance to breathe through a CPAP, or sometimes the patient is intubated. So there are signs and clinical indicators of acute respiratory failure. The correct avenue would be like drafting a query with all the elements to be sent to the doctor and see if we can get diagnosis of acute respiratory failure. A leading situation would be in the case of which you write a physician a query and you say, Dr. Smith, on reference to patient ABC, the patient is having difficulty breathing and got some laboratory values, you know, which are in line with acute respiratory failure. Can you please document acute respiratory failure on your chart? That situation is leading the doctor to obtain a diagnosis, and that's completely a big no-no. Then what is the provider role in CDI? Okay, providers are expected to provide complete, clear, accurate, and consistent documentation of a patient's health history, present illness, and course of treatment. This includes precise documentation of observations and evidence of medical decision-making for the determination of diagnosis and treatment plan, and along with the outcome of all tests and laboratory studies, procedures, and treatments. Providers should thoroughly document every diagnosis as comprehensive as possible in a specific diagnostic verbiage. In here, I'm going to give you a couple of clinical examples of the effects of accurate documentation and coding due to proper clinical documentation. I'm going to start by saying something really quick about it, how the diagnoses are integrated when the patient is admitted to the hospital. Number one diagnosis is the principal diagnosis. The principal diagnosis is the condition that is established after a study of being the main reason the patient was brought into the hospital or was admitted into the hospital. And then we have the comorbidities. The comorbidities are all the other diseases that, you know, are part of the patient problematic, but they are not the main reason why the patient came to the hospital. Some of those comorbidities may be CCs, which means comorbid condition, or MCCs, which is a major comorbid conditions, or maybe some others which are smaller, maybe like hypertension, or you can have like osteoarthritis or some chronic conditions which are conditions, but not necessarily being mid-size or CC or major size or MCC. So I'm telling you this for you to probably understand better the situation with this next example. This case was a 60-year-old male with principal diagnosis of acute renal failure. This falls into the DRG 684, which is renal failure without CC or MCC. Relative weight of this DRG is 0.615, and the geometric length of the stay is 2.2 days, and with an approximate reimbursement of $4,500. The provider of this case later on documents the patient has a decompensation of his congestive heart failure. Congestive heart failure is one comorbidity, and is one of those conditions in which they are not major conditions, they are not mid-size or CC conditions. CDI browses through the chart and finds an echocardiogram showing low ejection fraction and a BNP value of more than 850. This BNP is supposed to be not higher than 100, let's say, and the ejection fraction should be at the middle of the level between being low or high. This BNP being high is telling us that it may be an acute exacerbation of a heart situation. Despite the excellent treatment by the doctor and the patient's good response, by the second day in the hospital, no documentation of the kind or acuity of the heart failure has been documented. This situation is quite often, you see it quite often. The patient comes into the hospital, the doctor has a lot of things on his plate, and he's treating the patient for CHF. And the only situation, and that the doctor is being successful. The only situation he is not giving us the first and last name of my CHF. And at this stage, as I said before, there is no documentation on the kind and acuity of the heart failure. Okay, the CDI specialist deploys a query, and the attending physician documents acute and chronic heart failure. He has provided us with a middle and last name to our heart failure, and our DRG now becomes DRG 682, which is renal failure with MCC. This acute and chronic systolic heart failure is an MCC, and the relative weight now is 1.478, and the GMLOS is 4.3. It went up from 0.615, and the GMLOS being 2.2, and going up to 1.478, and the GMLOS 4.3. The higher relative weight and the higher GMLOS are representing a higher severity of illness of our patient. This patient requires increased resources, and the overall reimbursement for this DRG is approximately $5,000 more than the DRG 684. I have another example for you. This was the case of a 69-year-old female who was admitted with a principal diagnosis of acute pneumonia with hypertension, COPD, acute kidney injury, and altered mental status. All of these are the comorbidities, and you can see the AKA, which is acute renal failure also, is bolded, meaning that this is a CC, this is a mid-size condition. When he comes in, we establish the working DRG as being 194, pneumonia and pleurisy with CC. The weight is 0.863, and the GMLOS is 2.6, with a reimbursement of approximately $55.47. Upon revision of the chart by the CDI, they found documentation of history of dementia, probable delirium, and a neurology note stating probably encephalopathy. The attending provider documents altered mental status is improving in a progress note. I'd like to say something for you guys to understand what the term encephalopathy is. When you get a patient that comes in with an alteration of his metabolic system, sometimes in this case, the patient got pneumonia and most likely got dehydrated, so he developed acute kidney failure. And while that happens, the patient might develop a little drowsiness, a little alteration of his mental status, and maybe like low cognitive function at that time. So that, and then when they give this patient IV solutions and they start the treatment, for the most part, the mental state will come back to normal. That's the typical case of an encephalopathy. And in this case, we are seeing here that the attending provider said in a progress note that his altered mental status is improving. At this stage, there is unclear documentation of the altered mental status. Is it delirium? Is it encephalopathy unspecified? Is it metabolic encephalopathy? So a medical query is necessary. The CDI writes a non-leading query for the clarification of the altered mental status. Attending physician reviews the documentation and selects the option of metabolic encephalopathy, which is a major comorbid condition. Again, we have obtained a more precise description of the patient's altered mental status. Metabolic encephalopathy, as I was saying, is an MCC. And our DRG now is 193, pneumonia and pleurisy with MCC, with a higher weight, is now 1.3107, and a GLOS of 4.2. Before, we got 0.863 and GMLOS of 2.6 with the 184 DRG. In this case, the weight and the GLOS went up. And again, the higher relative weight and the higher GLOS are representing a higher severity of illness of our patient. This patient requires increased resources, and the overall reimbursement for this DRG is approximately $84.25. Before we got $55.46 of reimbursement. So those are the effects of implementing a good clinical documentation improvement in our practices. I'm going to go to the reimbursement side of it, and I'm going to give you a little anatomy of a DRG and the IPPS. A DRG stands for disease-related group, and IPPS is Inpatient Prospective Payment System. IPPS is a method of reimbursement on which Medicare payment is made based on predetermined fixed amount. Each DRG encompasses similar diagnosis and interventions thought to incur similar resources or cost. A single DRG is assigned to categorize an inpatient encounter of care. There are two main DRG systems. One of them is the MS DRG, Medical Severity DRG. That's the one I was telling you at the beginning that was implemented in 2007 by Medicare. And is used by CMS to standardize reimbursement of care provided to Medicare beneficiaries, as well as some private payers. APR DRG is a little bit more recent and is known as All Patient Refined DRGs. And it is used by some state Medicaid programs and private payers. And they use basically the same system to implement their DRGs, but they have an extra way of measuring the severity of illness. We have 4 degrees, like grade 1 is stage 1 is minor, 2 is moderate, and 3 is major, and 4 is extreme, the severity of illness. Whereas the Medicare MSDRG, it measures its severity through the presence or not of CCs and MCCs. So bottom line, the APR DRG is a little bit more complete. And CMS is looking into coming to a system in which they develop a model more like the APR DRG. So what are the elements of reimbursement? As I showed them to you at the beginning of the presentation, they are the hospital blended rate, the GMLOS or geometric length of stay, the relative weight, the MS-DRG assignment, and the case mix index. Hospital blended rate. This is a hospital-specific reimbursement rate associated with its unique patient populations to each and separate hospital. And this is like the base rate of that hospital. And it is composed, the hospital blended rates, of a base rate plus add-ons for local wage variations, local taxes, if the hospital has teaching capabilities, meaning is training residents or is training nursing personnel. And then it's also composed of hospitals with a disproportionate share of indigent patients. That's the hospital blended rate. The GMLOS. This is the national mean length of stay for a particular MS-DRG. By excluding outlier cases, the GMLOS reduces the effect of very high or low values, which would bias the mean if a straight or average arithmetic mean is used. GMLOS is used to determine per diem payment rate for patients transferred to post-acute care settings for a specified MS-DRGs. For example, if a patient is transferred to another acute care hospital before the GMLOS is reached, the hospital is paid twice the per diem rate for the first day of the stay and the per diem for each subsequent day up to the full MS-DRG amount. Relative weight. Relative weight derives from a complicated combination of length of stay, severity of illness, resource utilization, and cost. Each DRG has its specific value. Value of DRG's weight varies depending on different interaction with comorbidities. I have some examples for you, like the DRG5 is a liver transplant with MCC. This is a high weight DRG. The weight is 10.4390, and the GLOS is approximately 15.3 days. And the reimbursement of a liver transplanted patient is approximately $60,230. We have a DRG 70A. This is hypertensive encephalopathy with CC. And the weight in this DRG is 1.5717. The GLOS is 3.2 with an approximate reimbursement of $55.90. Then we have the DRG 313, which represents chest pain. The weight is 0.724. The GLOS is 1.7 with the approximate reimbursement of $42.46. How is the MS-DRG assignment? Okay, they are close to 1,000 DRGs. DRG assignment is driven by principal diagnosis, secondary diagnosis, procedures, gender, and discharge status. Case mix index. It is the average of all DRG weights for a specific patient volume and time period. The CMA is proportional to reimbursement and the overall severity of illness of a patient population. A low CMI may indicate DRG assignments that do not adequately reflect the severity of illness, the resources used to treat patients, or the quality of care provided. And I have some examples. This is the DRG calculation. This is the MS-DRG 293 for heart failure. And we have a relative weight of 0.6736, a hospital blended rate of 6,000, and an MS-DRG payment of 4,042. A geometric length of stay of this DRG is approximately 2.5 days. This is a CMI representation over time. In this case, you have a time period. This is like the from 10 October of 2016 to September of 2017. It's like the fiscal year 2016 and 2017. In this case, they were considering 4 different DRGs, the 291, 378, 470, and they show the description. This is CHF with MCC, 378 is GI hemorrhage with CC, 470 major joint replacement, which in this case is the higher weight, and the sepsis with MCC is the second in being the second higher weight for these DRGs. And you have the number of discharge cases. And sorry about that. In this case, the total is 902 patients discharged. You get the sum of all the relative weights. And then you calculate the CMI by dividing the total amount of the weights of the DRGs by the discharge cases, and we got a CMI of 1.6203. The reimbursement in this case is calculated by multiplying the discharge volume by the CMI by the blended rate, and we get the final amount that this hospital is going to get, which is $8,769.64. So, as you can see, I mean, integrating well our diagnosis and our DRGs is really, really important to obtain a good and probably a high reimbursement. I'm gonna just go to the final summary of this presentation. After this review, we can summarize the benefits of clinical documentation integrity. Clear documentation can have very positive results for hospital revenue cycles and offers an opportunity to improve coding and maximize reimbursement. A strong revenue cycle rests on accurate, timely data. As per a survey among CDI specialists, the top barrier to effectively implementing a CDI strategy is a lack of understanding among staff about the strong documentation practices. Back in 2016, there was a survey performed by the Black Book Market Research, in which they found 90% of hospitals that had implemented CDI had earned at least $1 million more in healthcare revenue and claims reimbursement. After implementing CDI, Arizona-based Summit Healthcare Regional Medical Center increased the organization's CMI by 20%, with MCC capturing rising 37% and CC capturing 22.8%. The case mix index and additional diagnosis capture translated to over $558,000 more revenue in just a few months. Health systems are transforming to a more complex, data-driven, value-based reimbursement model, as I was telling you a little while ago. A system of this nature demands clear, evidence-based documentation, which needs whole integrity of the health provider diagnosis and therapeutic approaches to ensure not only a healthy patient population, but a whole healthy and stronger and improved revenue cycle. Thank you so much. And I'm going to go to the question and answer section.
That's great. Thanks, Alejandro. Would you like me to read the questions for you?
Yes, definitely.
Okay. So first one, did diagnosis-related group change to disease-related group?
Can you repeat the question?
Yeah. Did diagnosis-related group change to disease-related group?
It's basically the same. The DRG is diagnosis-related group. That's the DRG is the abbreviated part, but it's the diagnosis-related group. They are the same thing.
Okay, great. And then next question, how do hospitals identify their per diem rate for transfer DRG payments?
Okay, that's a good question. There are part of the integration of a DRG is identifying what is the discharge status of the case. And if we look at the list of DRGs, there are some of them that are post-acute care DRGs. And so when that happens, you have to do a complete recalculation of the reimbursement. I mean, some of the post-acute care DRGs, I'm going to give you some examples, and it's like an intracranial hemorrhage or cerebral infarct with MCC. That is a post-acute transfer DRG. So there is a list, and when you find some of those, you have to recalculate the reimbursement for the hospital. In other words, the hospital who is receiving the payment to continue the treatment is going to receive the higher reimbursement.
Great. We actually don't have any more questions right now.
Okay.
So, one more just came in.
Mm-hmm.
How do you handle hard POA and HAC queries?
Another really important question. When we do our analysis, we have to look at the present on admission indicator. There are some conditions that if they are not present on admission, and if they are hospital-acquired conditions, Medicare is not going to pay for them. And you have to really and carefully look at the present on admission indicator of each claim. That's an excellent question. Thank you.
Great. What's the number one? Oh, sorry, go ahead.
Yeah, and that's especially important when you're dealing with like CCs or MCCs, which typically are paid at a higher rate. But if that condition is not present on admission, it means that probably the hospital didn't take good care of some general measurements to take care of the patient. So it might be penalized with less reimbursement.
Great. What's the number one strategy to increasing CC and MCC capture rates?
Increasing CC and MCC capture rates. We go back to doing a good clinical documentation practices. And, the CDI specialists have to read sometimes in between the lines. And let's say you have a patient with a cerebrovascular accident, and part of the therapeutic, some part of the diagnostic procedures of this case is just, let's say, getting an MRI. We as CDIs have to look carefully at the report of the MRI. Sometimes the MRI might say there is an area of vasogenic edema, and the doctor is giving us the diagnosis of CVA, but he's not telling us the patient got cerebral edema. So a query is an automatic and an immediate solution of trying to document that diagnosis. The coders or the CDIs, especially the coders, they cannot capture a diagnosis from a radiology study. So we have to query the physician for him to validate that hidden diagnosis. So that's a way of just being careful with our reviewing of documentation is a way of increasing the number of CCs and MCCs.
Great. Another question. How do you get the doctors to better document? This is a big problem.
It is. And my solution throughout my years of experience What I try to do is approaching the practitioners in a very subtle way. Number one, making them realize that we are acting as an ally of him. You know, we are trying for him to look better by integrating their diagnosis in a best fashionable way. Physicians have a lot into their plates, and you know, receiving this silly query sometimes is like an aggravation for them. But if you show them that by doing that, his or her profile is going to look better, that might be a reason to stimulate him into documenting better their cases.
Okay, we have no other questions at this time, so I can go ahead and start my closing remarks. And if any other questions come up, we still have a couple more minutes. So just a reminder that after the presentation today, by the end of the day, the CEU certificates and a link to the presentation recording and slides will be sent out to you over email. So look out for those just by end of day today. And if you have any other questions, you can always email us. We'd be happy to answer those for you. And I think that's all. And we still have no questions. So I think we can go ahead and close it up. So thanks so much, Alejandro, for presenting for us today. It was great.
Thank you so much. I really appreciate you.
Yeah, thank you. Thanks, everybody.
Bye-bye, Marie.
Bye. Thank you.